Hi, it is my pleasure to introduce Dr. Sarah Raatz. Dr. Raatz got her MD from Michigan State and a master's in science and clinical research at the University of Minnesota. She was one of our pediatric residents and did her fellowship here in pediatric obesity medicine, in which she is now board certified. She was hired into the Center for Obesity Medicine, run by Erin Kelly and Claudia Fox in 2021, and is one of our pediatric obesity physicians. And she's going to talk about the new guidelines and treatment options for people for children with obesity. Sarah?
Awesome. Thank you so much for that introduction. I'm really honored to be here and be able to talk to you all today. I'm going to hit the ground running. I have a lot to cover, maybe a little too ambitious with what I'm hoping to get through today. I have no relevant financial disclosures. And through this presentation, there are a couple of things that I want to make sure we cover. One is summarizing the key updates from the new guidelines, then recognizing when patients may benefit from additional interventions beyond the traditional lifestyle modification therapy we might be thinking about initially. And then spend a little bit of time discussing the most recent FDA-approved options for medications for treatment of obesity, since there's been a lot of change on this front in the last couple of years. So I don't think I need to tell this group that obesity is quite common among our pediatric population. The most recent NHANES data estimates that obesity prevalence is about 20%, so about 1 in 5 children. So I know that for everyone that's listening in, regardless of what type of clinical setting you're in, chances are this is something that you're encountering. So becoming familiar with these guidelines, learning what's entailed in them, what the AAP is recommending is very important. The guidelines were published just in January, so very new. And then just to set the stage a little bit, the guidelines do not focus on children under 2. So we're talking about 2 to 18. Data for the younger children is not featured in the guidelines. And then the other thing is that these are treatment guidelines. It does not focus on prevention. That'll be published in a separate set of guidelines from the AAP at a future time. So what are in these clinical practice guidelines? There are 13 key action statements, and those are the things that I'm going to focus on over the course of the presentation. But then there's 11 consensus recommendations as well. And the main topics focus on assessment and evaluation, discussion of comorbidities, and then what evidence-based treatment options are out there. Then thinking about what's new, what are the really highlighted changes and differences in these recommendations, I want to point out just a couple of things, and this figure comes directly from the guidelines. One is that we see obesity highlighted as a chronic disease, and we see a push to manage it in a chronic disease model. So thinking about that, we know that that means long-term longitudinal care. We know that that means ideally having a patient with a medical home. And we know that, as with many chronic conditions, obesity has a relapsing and remitting nature. So there are times when our patients may be doing quite well, and maybe they're not following up as often, or maybe they're really struggling and we're needing to adjust and manage that. The guidelines also highlight the fact that weight bias and weight stigma is a significant barrier to treatment and to adequate care. This is something that is pervasive in society. Unfortunately, it's also something that is very common within the healthcare system. And so, as uncomfortable as it can be, we need to acknowledge that that is a reality and start to make changes within our own practice to improve that for our patients. And then it also highlights the psychosocial influences and specifically social determinants of health. So thinking about adverse childhood experiences, racism, health inequities, and how those also not only influence obesity risk, but also influence access to adequate treatment. Additional things that are new. One of the big things is that treatment should be offered early. So this concept of waiting, and maybe if you have a child who has obesity, this thought that, well, they'll grow into their weight and we can just see what happens. That idea kind of needs to be put aside, and we need to adopt a little bit more of an aggressive approach and offering treatment upon diagnosis. However, the word treatment is an umbrella term. So treatment might look very different from one person to another, and certainly depends on the patient, depends on the provider, depends on, the whole story. So for one person, treatment might be discussing nutrition changes, while for another patient, treatment might be a little bit more aggressive, particularly if there are comorbid conditions. We need to treat the obesity and comorbid conditions at the same time, discuss and identify multiple different strategies to tailor obesity treatment. And then the guidelines specifically state that structured supervised weight management interventions can actually help with regulating eating disordered symptoms or disordered eating behaviors. And I will talk a little bit more about that in future slides. So to start with the first set of key action statements, these will focus on evaluation. So the first one highlights the need to continue to measure height, weight, and calculate BMI using our CDC growth charts, with which as pediatricians we're very familiar with at this point. It also does call out using the expanded growth charts for patients with severe obesity as just an additional assessment tool. So the guidelines use the definitions, again, that I think we're all fairly comfortable with. So thinking about overweight as a BMI between the 85th and 95th percentile, and obesity being a BMI greater than or equal to the 95th percentile. But we know when we use these CDC growth charts that they often fall short of what our patients need, especially for our patients with severe obesity. So this is a standard growth chart. It goes up to a BMI of 34. We can see that gold line is the 97th percentile, but then you can see these points that are floating above the chart, and particularly the most recent one floating way up here, and needing to be able to view these trends in a little bit more of an appropriate manner for this patient. So that's where the need to develop additional definitions for more severe obesity came from. And so the CPGs, the clinical practice guidelines, utilize the definitions of severe obesity as based on percent of the 95th percentile. So defining severe obesity as a BMI greater than or equal to 120% of the 95th percentile. And then you can see more specifically things broken down into class 1 obesity, and then within severe obesity, class 2 and class 3. So using our expanded growth charts that we utilize in our clinic, we have that same patient from the earlier slide, but now their growth chart point is actually plotted on the curve. And we can see that they have a BMI of about 34.5 and a BMI of 151% of the 95th percentile, which puts them in the class 3 severe obesity range. As I'm discussing obesity, there might be some people out there wondering, well, is this the best measure? And is it an antiquated thing, or why are we still using it? There are a couple of reasons and a couple of things I want to highlight about BMI specifically. One is it's feasible, and that's very important. So yes, there are other measures for anthropometrics that exist out there. Yes, we have fancy things like DEXAs and bioelectrical impedance and all of these things, but what is able to realistically be done in clinic, to be done quickly, to be replicated, and in that way BMI is quite useful. The other thing is studies have shown it's generally well correlated with measures of adiposity. So when we look at some of these other measures out there, we see that BMI is actually quite helpful. And then I've put a citation here for a study that looked at the specificity and sensitivity of BMI. And we can see that when we use that obesity cutoff for BMI, that once we get into the obesity range, there actually is quite a good specificity at detecting excess adiposity at 93%. And in fact, when we use that cutoff, there is actually a greater chance that we're maybe missing some children who have excess adiposity and are not being defined as having obesity. So certainly still a beneficial clinical tool and encouraged by the clinical practice guidelines. The next statement is about evaluating children, and you can see the recommendations are to perform a comprehensive history, to do mental health and behavioral health screenings, to evaluate for social determinants of health, do a physical exam, do diagnostic studies. I'd say overall, this just essentially is a way to say treat obesity as you would other chronic health conditions. You need to do the relevant history, you need to do the appropriate screenings. We need to be treating this again in a chronic care model. I've included some examples of relevant history that should be included for patients for whom you're concerned about obesity, or especially for our patients with severe obesity. So thinking about things like weight trajectory, doing a more focused family history. So especially thinking about family history of obesity or obesity-related complications like type 2 diabetes, high blood pressure, et cetera. And asking about family history of bariatric surgery, because that can be helpful in understanding if there's a family history of more severe obesity. We need to think about medication history, specifically if our patients have been on medications that influence their weight one way or another. For example, were they placed on Abilify and that really significantly impacted weight gain? Was there a time when they were on a stimulant for their ADHD treatment and weight significantly decreased? And understanding that and how medications may have influenced things is very helpful and helpful for guiding treatment and counseling patients. For social history, a couple of things, again, just to focus on specifically in the context of obesity, eating routines and schedule and the environment of food around the house or home, bullying at school, especially when we're thinking about weight bias, weight stigma, and social determinants of health. We also need to think about a detailed nutrition history. And this is where we're not only asking about what our patients eat in a day or what their daily intake really looks like, what kind of foods they eat, but also screening for disordered eating behaviors. So we know that disordered eating behaviors do occur at a higher rate with our patients or within our patients with obesity. And so asking about those things, asking about things like skipping meal or compensatory behaviors, things like that is important. And then asking about physical activity. And certainly this is not an exhaustive list. These are just highlighting a few things, and the guidelines do go into more detail. For key action statements 3 through 8, I'm going to kind of lump these together because they are all focused on identification of comorbidities and diagnosing these. The comorbidities highlighted in the key action statements are lipid abnormalities, abnormal glucose metabolism, liver function, and high blood pressure. There are more comorbidities that are discussed in the guidelines, other things like PCOS, sleep apnea, some of those more common ones that we might think about related to weight health, but these are the ones that are really focused in on the key action statements. So the key action statement 3 really summarizes this in a whole, saying that for children 10 years of age and greater with obesity, we need to be screening for these things. And then thinking about maybe more specifically looking at lipids abnormalities in children and adolescents with overweight, but especially for our adolescents with obesity, we need to be looking for these comorbid conditions. And then the next action statement is just discussing treating these comorbid conditions as we embark on treatment with obesity. So, why are we screening? What's the data behind this? We know that obesity and excess adiposity is associated with cardiometabolic risk and cardiometabolic disease. And so these are just a couple of the statistics that are highlighted in the clinical practice guidelines. They certainly highlight more, but just thinking about each of these things that we're discussing screening for. So lipid abnormalities being 3 times higher in adolescents with obesity compared to those with a healthy BMI. So when you look at the numbers, we're talking 43% of our patients. I would certainly say I see this all the time in clinic. It is very common. Thinking about the prevalence of non-alcoholic fatty liver disease among children with obesity, and we see a range of estimates, but it could be as high as 34%. So 1 in 3 children that come into my clinic having NAFLD is very significant. We need to be looking for it. And then also considering that obesity is a very strong risk factor for hypertension. I also want to highlight a few things about specifically type 2 diabetes and impaired glucose metabolism, and I'll come to back to this in a future slide, but estimates from NHANES data shows that 18% of adolescents have prediabetes, and it's over a quarter of our patients with obesity that have it. So it's extremely common. We need to be looking for it. There's a higher risk of type 2 diabetes in these patients and higher risk of cardiovascular disease over time. What's more concerning is that when you have patients who then develop type 2 diabetes as adolescents, it is aggressive. It accrues complications quickly, and complications, not only a single complication, but patients develop multiple complications early in life. So looking at data from the Today study or a follow-up of the Today study, we see that at 26 years of age, so young adults who had youth onset type 2 diabetes, they're already struggling with many of them are already struggling with at least one microvascular complication, and about 28% of them have 2 or more complications. So this is very significant, and again, very aggressive and needs to be both screened for and also managed aggressively. So in terms of how do we do these screenings, I took the key action statements 5 through 8 and really just summarized them down into a table where you can see the the tests that are recommended. So fasting lipid profiles for looking for lipid abnormalities. This is slightly different than the general recommendations to check a lipid profile at some time between 9 and 11 to look for familial high cholesterol. So this is a little more specific. And then looking at fasting plasma glucose or A1C to screen for diabetes or type 2 diabetes. The guidelines do recommend, or do mention, I should say, oral glucose tolerance tests. But I put those in parentheses because, as you can imagine, the feasibility of doing that within a primary care setting or an outpatient clinic visit is a little more tricky. So using the plasma glucose or A1C would be perfectly reasonable. And then screening for NAFLD with an ALT, and then screening for hypertension with our blood pressure checks. So moving on from those initial key action statements, we then get into key action statements that are more related to treatment. And so the first statement here is really focusing on the fact that children with overweight and obesity should be taken care of in a medical home. There should be a chronic care model that's using family-centered interventions, that's non-stigmatizing, and really takes the time to acknowledge obesity's biologic and social drivers as well. This is a quote directly from the guidelines that I think is really important. Essentially, we need to acknowledge that obesity has been on the receiving end of a lot of stigma, and our patients have experienced that stigma. There's been this belief that obesity is a result of personal choice, that it's just calories in, calories out. Our patients just need to work harder and just need to be more active. But what we're learning is that it's actually a lot more complicated than that. There's a lot of genetic, physiologic, socioeconomic, environmental contributors to this complicated disease. And if we don't acknowledge that ourselves, and if we don't explain it to our patients, we're doing them a disservice. The guidelines outline, I would say, not every single thing out there, but certainly a lot of the very important factors that show all the different ways that our environment, our individual factors, our community can influence weight, influence eating behaviors, et cetera. So if you look at this list, many of these are really outside of our patient's control. So we can't get into our heads that this is, again, a matter of personal choice, especially when you look at some of these individual factors that play into genetics or other health concerns that our patients might be struggling with. So I'm going to take a super brief segue into how I approach this in clinic in case it might be helpful, or just to give you an idea of what that education looks like if you are referring patients to come to our clinic. I like to outline for our patients that we need to consider aspects of the environment, our psychology and biology that all play a role. This is arguably a little bit simplified to just provide that patient education, but I think is still effective. So for example, in the environment, I'll talk to them about, what kind of food is at school? What kind of food is at home? What access do you have to activity? And that could be related to, is it really cold outside because it's winter and we're not going out as much? Or is this, whether or not you have gym class at school? Is this whether or not the sport you're involved in is in season right now? But also thinking about how far away is the nearest store, what kind of food is there, what kind of restaurants are nearby, what fast food is nearby that might be more convenient, and what drives us to go to those places. And then acknowledging our psychology. So thinking about things like depression, anxiety, how they might influence our eating habits, eating behaviors, boredom, stress. Again, not a fully comprehensive list, but important things that come up very often in clinic. And then really highlighting that biologic piece. So we know that 40 to 70% of what determines our size and our shape comes from our genes. So highlighting that genetic predisposition, talking about how this is generally something that runs in families, but then acknowledging that there's a lot of other factors that influence that biology: sleep, weight-related health complications themselves, such as the development of insulin resistance or sleep apnea, medication use, and then other health complications. For example, I highlight ADHD here because it's something that I'm often talking about in terms of how ADHD may influence impulsive eating habits, for example. And as I do this education in clinic, I've also been drawing like a big circle around all of this and acknowledging that COVID has also played a very significant role in many of these things, specifically when we're thinking about depression, anxiety, our environment, school, doing remote learning, then back into in-person learning, et cetera. And it certainly resonates with a lot of our families. So in In addition to just providing that education, which I think is really the foundation of a non-stigmatizing approach, there are some other important things we need to think about. And that is considering the environment our patients are in, making sure we have the appropriate equipment to assess our patients. So for example, blood pressure cuffs that are the appropriate size, and then also an environment that's comfortable. So our seats that are in the exam rooms, are they narrow? Do they have arms, or do we have comfortable seating, doesn't have arms, more of a bench that allows people to sit comfortably during a visit? And then the other thing that I want to highlight, and I think is very important, and probably the easiest thing that all of us can start doing right now, is using person first language. And this is highlighted certainly in the clinical practice guidelines. This should be the case when we're documenting. This should be the case when we're discussing patients with one another as healthcare providers to begin reducing that weight bias and weight stigma. So just like any other chronic health condition, our patients aren't defined by their obesity. So it should be a 16-year-old female with obesity, not an obese 16-year-old female. There's also some good data out there to show what terminology is preferable during a visit. So things like unhealthy weight or gaining too much weight for health are more preferable to patients, as opposed to words that come off as more offensive, like obese, overweight, certainly things like morbidly obese, large, fat, etc. So opting for more weight neutral terms. So for example, if I'm getting a family history, I don't ask if there's a family history of obesity. I might say something like, are there other members of your family that carry extra weight? And that's a little bit more neutral. The next action statement highlights the use of motivational interviewing. And I'm not going to spend too much time on this because I think we're all relatively familiar with the concept, because it's certainly not something that's unique to obesity treatment, but is encountered in treatment for multiple, all sorts of different chronic conditions. But with motivational interviewing, especially when this topic can be quite challenging to bring up, at least initially, we need to start with these open-ended questions. So one of the question examples that's highlighted in the guidelines is saying something, again, very neutral, like, what concerns, if any, do you have about your child's growth and health? And just see where the family is at. This is also very important for just assessing readiness for change. And that readiness for change could be all over the board for families. And in order to start effective obesity interventions or obesity treatment, we need to know where our patients are. If they're not ready to make changes, that doesn't mean that we don't follow them. That doesn't mean we don't evaluate for comorbidities. We need to keep doing that, but they might not be ready to implement more intensive lifestyle changes. The next key action statement talks about providing or referring to intensive health, behavior, and lifestyle treatment. So for example, that would be referring patients to our clinic, though this is also something that primary care providers or other healthcare providers could start implementing in their own practice within what's reasonably feasible, which we'll talk about in a second. I think the biggest challenge when it comes to these guidelines and the recommendations that they make on the behavioral interventions is that there is really not a set intervention that works. The one thing that really is highlighted is that intensity is important. And so they highlight these guidelines that are also mentioned by the USPSTF, and that's that effective interventions include 26 hours or more in terms of contact hours over 3 to 12 months. That is a lot of time. It's certainly more than I see patients over the course of a year, and would arguably say that that's not feasible for a primary care setting. But when we look at the outcomes, looking at all the different trials out there for lifestyle modification therapy, it's this intensity piece that seems to have the best data in terms of actually seeing some changes in outcomes. The guidelines also recommend that these interventions be face-to-face. There's still more data that's evolving on how effective are virtual interventions. And I think certainly with the pandemic, we're all much more tuned into the utility of virtual platforms, but the data and evidence behind those is still a work in progress. Ideally, these interventions should be family-based. That is especially so when we think about our younger children. And then tailoring the treatment for as our patients are getting older, as they're developing their independence and teenage years, focusing the goals more towards them, but still involving the family. And the intervention should be multi-component. So we're not just talking about nutrition. We're not just talking about physical activity, but we're trying to address multiple different aspects of care. This, again, is a little tricky because when you look at the data behind all the different lifestyle intervention therapies that have been studied, is they all vary slightly differently. Do they most have a nutrition and physical activity component, but what that looks like and what other components are included is a bit variable. So there isn't something that necessarily is the ideal approach and the ideal balance of these things, but just acknowledging that we should be covering multiple different aspects of our patient's care is important. So I know this can certainly seem daunting, especially when we think about the primary care setting, but I think there are a couple of things that are very reasonable and realistic for primary care physicians to at least start doing sooner rather than later. And first and foremost, it's just thinking about more frequent appointments. I don't expect that a primary care physician is going to have time to spend 26 contact hours with a patient over the course of 3 to 12 months. But if you have a patient with severe obesity and they're in for a well child check, the follow-up plan shouldn't be, follow up in a year at the next well child check. We need to have those more frequent appointments in place. There might be a referral to come to our clinic or to go to some other community-based resource, something like that. But we also know that, attrition rates or no-show rates might be a bit of a challenge. So having that follow-up in primary care to confirm, did our patients start something? Is there something else in place? Because a lot can happen over the course of a year, and we need to, again, follow that chronic care model. More frequent appointments also allow more time for a detailed history and to be able to set some initial goals. So, I think a lot of times we can rattle off these 5, 2, 1, 0 goals and say, okay, well, 0 sugar sweetened beverages. And that's great. It's a great idea. But without asking your patients really what they're drinking, what they're having, is that a realistic goal for that patient? Maybe they're not even drinking sugar sweetened beverages at this point, or maybe they're doing 3 sodas a day. And so going from 3 to 0 is a huge change, and we need to take it a little bit slower than that and set some more realistic goals. The recommendations that we discussed earlier about screening for comorbidities is something that can also be implemented fairly easily in a primary care setting and may affect that motivation for change. So there is adult data that shows that diagnosis of comorbidities does affect motivation. And so, especially if we're not trying to focus so much on weight and weight as the only outcome, maybe we want to screen for comorbidities. And if we identify high cholesterol, for example, have that be the focus and what we're really paying attention to. So if a patient has elevated triglycerides, let's focus on the nutrition changes that address that. Let's follow that and look for progress. So the challenges, again, time, this comes both from the provider standpoint, but then also for the patient and the family. So 26 contact hours is a lot. That's a lot of time for providers to spend time with providers where patients are missing school, family members are missing work. And I can see how attrition rates within that would be quite a challenge. We also know that the studies that look at the more time-intensive interventions have much smaller recruitment rates. And so you can imagine that maybe part of the retention problem in those studies is that it is so time-intensive. And so is this a feasible and realistic thing to implement long-term for our patients, especially considering that chronic care model? It might be a challenge. Some of the other difficulties are thinking about provider confidence and knowledge and, feeling like we can conduct the appropriate motivational interviewing or nutrition counseling, thinking about, again, attrition rates, which we've talked about, but then insurance coverage, especially when we think about engagement in community programs, or does insurance cover visits with a dietitian? And that could certainly be variable. And then we also think about resources and programs. So again, we have a weight management clinic here at the university, but there are many places that don't have that type of program, especially when we think about our patients who live in more rural settings where the next big academic center is many hours away. And then we have to consider efficacy, and this is certainly a challenge. I put the reference here for the more comprehensive report looking at the lifestyle trials and the outcomes. It does mention that overall, looking at the lifestyle RCTs, they report that 35% of them demonstrated any difference in BMI or BMI standard deviation score. So already off the bat, we're thinking, okay, that's 65% where there isn't much of a change. But then we also have to think, okay, we saw a change, but was it a substantial change? Was it a clinically significant change? And that's where there can be some struggle. I will also point out that these trials also included patients who have overweight and may not have focused necessarily on our patients with severe obesity, in which treatment can even be a little bit more challenging. So the clinical practice guidelines outline that for patients that do achieve some sort of change with lifestyle modification therapy, that change is usually relatively modest with a 1 to 3% BMI percentile decline. So considering these challenges for lifestyle modification therapy, that's when we have to start thinking about, well, what other interventions are out there? What more aggressive interventions can we offer? And the guidelines do say to offer adolescents 12 years of age and older the option of pharmacotherapy according to the medication label, which considers, the benefits, risks, things like that. And so for a long time, there weren't really many options out there. We had orlistat, which is a gastrointestinal lipase inhibitor. It's technically approved for adolescents 12 years of age and older. It's very rarely used due to side effects and also due to limited efficacy. And then we have phentermine, but if you look at the actual FDA label, it's only approved for adolescents over 16 and for short-term use. So when the recommendations are to use things according to label, for a long time, we didn't really have anything. And then that's where a lot has begun to change over the last couple of years in obesity medicine, and it's been a very exciting time. So in 2020, we had the addition of liraglutide or Saxenda, which is a daily GLP-1 receptor agonist that's approved for obesity treatment in adolescents 12 years of age and older. And then we also had setmelanotide, which I'll just mention for completeness sake, but we'll note that it's very rarely used as it's used for treatment of very specific monogenic obesity cases. And then the biggest change that I will highlight towards the end of this presentation are the newest medications that were added just in 2022. So now we have topiramate and phentermine approved for adolescents 12 years of age and older, and that's approved for long-term use. And then semaglutide or Wegovy that was just approved at the end of 2022. And I will spend a little bit more time talking about those. So knowing that pharmacotherapy is an option, one of the questions that I am often asked is like, well, who's going to be prescribing these things? So when I have residents come and rotate with me in clinic, the question is like, I want to go in primary care. Is this something I should be doing? And I think it's something that's going to take time. So just like any other prescription medication for a chronic health condition, providers need to be comfortable. They need to feel like they understand the medications, the adverse effects, the benefits, the risks, et cetera, before they prescribe them. And so sometimes that learning curve makes it a little challenging to get started and get going. But when we think about the prevalence of obesity and severe obesity, limiting the prescription or pharmacotherapy options to just a specialty center may not be feasible in the long term. And it might be something that eventually we see more primary care providers becoming comfortable with this type of intervention. This is also my cue to plug a couple of different resources for providers that are interested in learning more. One is our conference. Our center puts on a conference every year that really focuses on the logistics of how to do this and how to prescribe medications. We just had it in February, but we will have it again in 2024. And then the other is Dr. Claudia Fox is spearheading an obesity handbook that will be published by Springer and goes into a lot of detail about this and what this really looks like in practical clinical practice. So if you are interested, if you want to learn more and feel like you don't have the tools, those are excellent resources. The last key action statement is involves referral to bariatric surgery programs. And the key action statement recommends this for adolescents 13 years and older with obesity. I would say the wording of that is a little misleading because it's not necessarily all patients with severe obesity who meet criteria for bariatric surgery. We look at the specification of class 2 versus class 3 to determine eligibility. So if you have class 2 severe obesity and a significant weight-related health complication, then bariatric surgery may be a reasonable intervention. Or if you have class 3 severe obesity, the presence of the comorbid condition is not necessarily required, but is often seen. And I want to highlight too that these are not new recommendations. This is an AAP policy statement that was published in 2019. And so the new clinical practice guidelines just reiterate this previously established recommendation. And I think that, bariatric surgery sometimes comes across as, again, like a very extreme intervention. And there might be a lot of, it might take people off guard, especially if they're reading it for the first time, thinking about this, especially in pediatric populations. I do want to highlight very briefly one of the really big benefits of bariatric surgery. So this diagram shows or illustrates the biologic nature of obesity and highlights how traditional lifestyle modification therapies might be limited by biologic drivers of weight and weight regulation. So for example, if you have a patient who goes on a calorically restricted diet, maybe they lose a little bit of weight, they have these homeostatic mechanisms to defend that higher body set point for their weight. So their hunger is increased, their satiety is decreased. So when they regain weight, which is very often seen, we can't attribute this to them being lazy, not trying hard enough. We need to think about the fact that there are these biologic drivers. And that's when we compare it to bariatric surgery, where we have the possibility to reset that set point. So now we've achieved some clinically significant weight loss through surgery, and our body's not fighting to get back to that original set point. The other thing I want to specifically mention for bariatric surgery is it is effective for adolescents. So this is data from the Teen Labs cohort, which is the largest US-based prospective cohort of adolescents who've undergone bariatric surgery, whether that's a Roux-en-Y gastric bypass or a gastric sleeve. And you can see that when it comes to weight loss outcomes, the adult cohort and the adolescent cohort are very comparable. But more importantly, and I want us to pause and remember what I mentioned earlier about type 2 diabetes in adolescents and how aggressive of a disease it can be. When we have patients with diabetes who undergo bariatric surgery, if they are doing this during adolescence, they have a 27% greater chance of diabetes remission as compared to adults. And we can see that after 5 years, there is a higher percentage of adolescents who remain in remission from their type 2 diabetes as opposed to their adult counterparts. Similar trends can be seen when we look at remission of hypertension. So adolescents being more likely to achieve remission of hypertension after bariatric surgery as compared to adults. So when we think about waiting until patients are adults to undergo this type of surgery or this type of procedure, there is benefit to early intervention and possibility of improved outcomes. I certainly can't talk about these guidelines without acknowledging the fact that they have caused quite a stir. I've never gotten so many text messages from friends and family members who are not in the medical field, saying they've read about it in the news, they've seen it in social media, and I know there are a lot of varying opinions out there. I just want to take a second to highlight a couple of things. These clinical practice guidelines do not state that all children with obesity should be immediately started on medication or immediately have bariatric surgery. What it does do is, yes, call for early intervention for children with obesity, but that intervention is a spectrum. And while certainly things like medication and bariatric surgery have their place, especially for our patients with severe obesity and weight-related health complications, it's not necessarily something that all patients will want to pursue, or that's necessarily indicated for all patients. These guidelines also do not claim that anti-obesity pharmacotherapy is a replacement for lifestyle modification therapy. We think about doing all of these things together. If we do not acknowledge the fact that these evidence-based treatments exist and we kind of close off that treatment option for our patients, again, we do them a disservice when we're talking about treating a biologically driven disease. I think there are also a lot of assumptions about what obesity treatment is, and what I want to clarify is what it is not. So obesity treatment does not have to be weight-centric, demeaning, it's not dieting, it's not focusing on a blame and shame for our patients, and it's not only talking about eating activity. It's inclusive, it's compassionate, it can be effective, and it really highlights that education of the biologic underpinnings of weight regulation. And so we need to think about how we can approach this, but also, again, maintain that positivity. And I'm going to do a little plug for our clinic too. And this was a very recent survey comment that we got, and just highlights, I think, the way that we can approach treatment and how it can be received by our patients. So this family acknowledging that they were treated with respect and dignity. Again, this does not have to be a demeaning thing. It should not be demeaning. It should not be a blaming or shaming experience for our patients. The other thing that comes up very often is this concern for development of eating disorders and disordered eating behaviors, which, again, disordered eating behaviors are quite common among our adolescents with obesity, but we know that engagement in a supervised obesity treatment can actually be protective. So this review paper was mentioned in the guidelines, and I went to the original article and pulled a figure from it to talk about, when we think about the disordered eating behaviors, what happens in a self-directed situation for our patients with obesity versus what happens when they're in a supervised treatment where we're talking about healthy, sustained behaviors. We're talking about eating regularly. Like, we want you to eat. We want you to eat throughout the day. We want to just improve your diet quality, but not focus entirely on like restricting. We want you to engage in activity that you find enjoyable. Like, I love that. I don't have specific things of like, this is the workout regimen you need to cover, or you need to follow. Find something that brings you joy. And so I think this is an important thing that we need to acknowledge about what that treatment looks like. Okay. And then in the last few minutes here, I just want to talk about some of the new advances with regard to treatment options. So as I mentioned, there have been 2 medications that were recently FDA approved for the treatment of obesity. The first is phentermine and topiramate, which was FDA approved in the summer of 2022 and is FDA approved for long-term use. And that's in comparison to phentermine monotherapy, which is approved for short-term use. In terms of mechanism of action, phentermine is a norepinephrine reuptake inhibitor, and topiramate, with regard to mechanism of action, how it affects weight, is a little unclear, but possibly involved in glutamate neurotransmission or decreases in neuropeptide Y. Because of the phentermine component, it's given daily in the morning. So the largest randomized clinical control trial that looked at use of phentermine and topiramate had patients randomized to placebo or to a mid-dose phentermine or top-dose phentermine. And you can see the differences in the primary endpoint of BMI change from baseline in this graph. When we look at comparison from placebo to mid-dose, the change was about 8%. And when we look at placebo to top dose, the change was about 10%. And here we can see how many patients or percent of participants who were able to achieve that BMI reduction of 5, 10, and 15%. 5% BMI reduction is generally considered substantial enough to be clinically significant. And you can see that it's a relatively small portion of patients on the placebo, which did involve lifestyle modification therapy and intervention, as compared to the treatment arms. And then we look further down the line on how many achieved 10 to 15%. That placebo group was not effective in achieving these results as compared to the medication group. Looking at the other endpoints, they did take into account cardiometabolic factors and did notice specifically improvements in HDL cholesterol and triglycerides that was significant between the phentermine topiramate group and the placebo group. There were no other statistically significant changes of the other measures, which includes concerns for possible increase in blood pressure or heart rate that might be experienced with phentermine use. There were also no clinically relevant differences on mental health questionnaires or cognitive assessments, which I know can come up at times with use of topiramate, and no issues with drug use, withdrawal, or dependence that might come up with concerns for phentermine use. There were some serious adverse events noted. One was a bile duct stone within a week of completing the study. The other was depression and suicidal ideation, initially thought to be related to the medication, but after discontinuation, it continued for about 100 days after, so then deemed not related to the study. And the last thing I want to cover is semaglutide, and I think this is the one that has really made a splash in the headlines, also known under the brand Wegovy. And it was very quietly FDA approved for adolescents in December of 2022. And so this is approved for adolescents with obesity and approved for long-term use. It is a GLP-1 receptor agonist. And then one of the biggest differences, especially when it comes to my patients and what is appealing to them, is it's given once a week as opposed to daily, like liraglutide. And this figure really shows the profound change in BMI from baseline that was achieved over the course of this study. So after 68 weeks, seeing about a 16% BMI reduction. And to put this into context, when we compare that to the outcomes of the liraglutide study, although it was a slightly shorter period on the medication, the liraglutide study achieved about a 5% BMI difference. So comparatively, 16% is really, really surprising results and really exciting for those of us that are working in the obesity community. There's another table that does highlight the endpoints of treatment, and I'm going to focus in on the cardiometabolic risk factors. So this just this portion of the table, and want to highlight then when looking at other endpoints like waist circumference, hemoglobin A1C, blood pressure, cholesterol, we do see positive effects in the direction the desired direction in the treatment group as opposed to the placebo group. This study also highlighted quality of life and found an improvement in quality of life scores for patients who are on treatment. And this was driven largely by changes in physical comfort. Common adverse effects were GI distress, specifically nausea, vomiting, and diarrhea, more often seen in the treatment group, which is kind of expected with this class of medication. They were generally mild to moderate and short duration. And then for those in the treatment group, these symptoms peaked during the escalation period and tended to resolve after. For adolescents in the treatment group, nearly 90% were able to complete the study at the goal semaglutide dose of 2.4 milligrams every week. So generally quite well tolerated. In terms of serious adverse events, the study did note gallbladder disease, so specifically gallstone formation, and one incidence of cholecystitis in the treatment group, so about 4% of participants, and that is a known possible risk of GLP-1 receptor agonists that we will counsel on before starting this medication. I'm coming back to this slide because I know I compared it to liraglutide in terms of the degree of difference we see here, but I also want to highlight a few other things. One is the substantial change we see here and how exciting this is for those of us, again, working in the field where this number is an average. So we know that there are some patients who are maybe not having quite this effect, but then also some people who are having more. And when we think about those people who are responding even better to this medication, we're entering into BMI differences that are seen with bariatric surgery without undergoing surgery. So this kind of represents the beginning of this new frontier for the possible power of pharmacotherapy interventions to make a really big difference for our patients. The other thing I want to highlight here is you can see at 68 weeks, the medication was stopped, and we can see by 75 weeks, although patients were continued on lifestyle modification therapy, that BMI begins to rebound a little bit. This reiterates and this highlights that obesity is a chronic health condition. When we are starting medications for treatment of obesity, we start them with the anticipation that this is going to be a long-term treatment, just like medications for any other chronic health condition. There still remain challenges. Yes, we have significantly improved and expanded the options when it comes to FDA-approved medications. But when we think about our patients under 12, there's really not much out there at this point, and a lot of work that needs to be done. We still run into issues with insurance coverage. which is a significant barrier. I have seen this identified as a reason why we shouldn't be recommending these therapies for patients, but I would say that these type of guidelines help us to advocate for our patients and advocate for coverage. So we should embrace the fact that the guidelines are encouraging use of these things so we can see improvements in coverage in the future. We do run into issues with shortages, although it sounds like right now there are many different specialties that are experiencing shortages in various medications. And then we also know that there are knowledge gaps in treatment of obesity and access to care, and then parent and patient comfort. Whether parents consider this a right choice for them. And a lot of that can be driven, again, by that messaging. We've been told again and again that our patients just need to try harder, just need to work harder. They just need to move more. When we know that a lot of times those interventions don't yield significant results. So in conclusion, obesity is a complex biologically driven disease with very significant psychosocial influences. Our pediatricians and other healthcare providers should be screening for and treating obesity. What that treatment looks like will vary, but we shouldn't be delaying it. Comorbid conditions are very common among adolescents with obesity, and screening is necessary. At this time, there really isn't a standardized approach to treatment, especially when we think about that lifestyle piece. It's going to depend a lot on what patients are ready for. So using that motivational interviewing, figuring out where they are, meeting them where they're at, but also what is feasible within that clinical practice, or what resources are available, what community resources are available, what specialty clinics are available. But then we also need to acknowledge that there are more advanced treatment options, including pharmacotherapy and bariatric surgery. It's something to consider for our patients with severe obesity, and especially for our patients who, even at a young age, are already developing these weight-related health complications that can be quite serious. And we need to think about the fact that these are kids developing things like fatty liver disease, insulin resistance at a young age, and thinking about what their quality of life and what their health is going to look like long-term as they live with these health complications. And so that need to be aggressive and address these things head on is certainly important. And with that, I'll end on this lovely self-portrait that one of my patients drew, showing me the snack she opted for after school. And I'll take any questions.
Thank you so much. That was outstanding. We do have a question coming in from one of our bone marrow transplant physicians, just noting that that is a special population that may have some challenges with dyslipidemia or carrying extra weight, and wondered if you could comment on chronic health conditions in addition to the chronic health condition of obesity, and if your clinic cares for that.
Yeah, so we absolutely do. We see patients, we get a lot of referrals from our specialty colleagues, and have patients with varying health needs and can be quite complicated. Certainly thinking about that lifestyle treatment and what that would look like, and again, having that time to really dive into that patient's like individual needs and what we can accomplish within that, and within like what might be required for management of their again, complex health needs. I think especially in some of these populations where there are other biologic drivers of obesity and other biologic drivers considering like medications that might promote weight gain, that's where we need to think about some of these more advanced treatments and treatment options that can balance that and counteract that. And it does get quite complicated.
Great. We have a question from Sarah Espinoza in our Division of General Peds and Adolescent Health. Just hoping to hear your reflections on the sort of relapsing, remitting nature of obesity as a chronic disease, and sort of your observations when somebody's in a period of doing better, what's going on for them, what seems to help get their disease under better control, and when things aren't going as well, are there common themes of what you're seeing?
Yeah. It's a great question. And I would say the short answer of it is it depends. I have a lot of patients for whom, for example, their mental health plays a big role in whether they're quote unquote, I don't want to say doing well, makes it sound like I'm only, again, focusing on the weight side of things. But for example, I might have patients that come and they tell me, gosh, like my anxiety, my depression's been worse. It's really affected my motivation to be more active, my motivation to follow, my healthy eating habits and things like that. Certainly family stressors. I've had families come tell me like, a grandparent was diagnosed with cancer. And so they've spent a lot more time eating out and eating fast food because they're in the hospital in and out. I've had patients that certainly noticed that, gosh, the winter holidays, we have all these, we're out of school, there's less structure, we have all these holiday celebrations, plus it's winter and we're not as active. And sometimes that can make things a little more challenging. So it kind of depends. And again, that's where getting that detailed history and kind of getting to know your patients can be particularly helpful.
I really like the way you gave us guidance about language to use to bring up carrying extra weight with patients. And one thing that I find is I'm trying to be more careful and kind with my words, but sometimes the parents are not doing that. Do you have any tips about how to gently correct a parent who may use some of those words in front of their child that aren't as supportive?
I flat out just call it out. Because you're trying to ultimately build rapport with the family, and that absolutely includes this patient in front of you you're trying to support. So I have had parents use the word fat in my clinic, and I say, nope, we absolutely don't say that. That is, that's not how we're going to think about this, and just kind of redirect from there. And again, I think that going through the steps of kind of drawing out and outlining what is contributing to all of this, again, is where we get a lot more of that buy-in from our families. And you can certainly see, from my personal experience, you can see parents come in very, very guarded. And I think they come in ready for a lecture and ready to hear a lot of that shame on like, well, why are you doing this? Why are you giving your child soda? That's ridiculous. But to have it laid out the way we kind of walk through it, you can see them, again, kind of putting down some of those barriers, feeling more acknowledged, more seen. And I think that just overall helps. And then the language piece of it is very important, again, for patient facing. But then I really think we also need to start thinking about how we're communicating to each other as healthcare providers, and think about open EMRs. Think about how you're documenting as patients are reading these things as well. Use neutral language. It will only serve you well.
Yeah, I think the EMR is a great point, because you probably will add things to the problem list, and all of our patients are smacked in the face with their problem list the second they log into Epic. I believe you can modify it so it displays differently, but that's probably an area of work for all of us with the open notes. Yeah. I think there are lots of questions about sort of next steps if someone's not responding to intensive health, behavior, and lifestyle treatment, how to use other healthcare professionals to reach up to those 26 contact hours, I think is a really interesting idea. We're clearly just going to have you back for another grand round sometime soon. Thank you so much for just outstanding presentation. This was really great and left us all with a lot to think about in our daily practice. Thanks to everyone in our audience. Have a great day.
Thank you.
Bye, everyone.